Okay, I'd like to call this meeting to order and have the clerk of the board do a roll call, please.
Supervisor Johnson?
Present.
Supervisor Gould?
Present.
Supervisor Watson?
Present.
Supervisor Angus?
I hear.
And Chairman Bishop?
I am here. So this morning, the Board of Supervisors may by motion recess into executive session to receive legal counsel from the board's attorney on any item contained within this agenda pursuant to 38-431.03. So this morning, we'll be discussing and possibly taking action on the update from the County Public Health Director to the Board of Supervisors regarding recent issues, actions, events, and county responses regarding COVID-19. And we'll be taking any necessary actions based upon the update that Ms. Denise Burley will be giving us. Good morning.
Good morning.
Or good afternoon.
Afternoon, right?
Yes.
Madam Chair, members of the board, thank you for letting me present today. Additionally, on the phone, I have Anna Scherzer, who's our epidemiologist for Mojave County for our department. And then I also have Mayor Schumacher, who is our temp epidemiologist, who will be assisting really with the presentation this afternoon. And I hope there are lots of questions and it's a robust discussion so that we can work through some of the data questions that you may have. So I would like to go through the agenda that I'll be going through with the 3:30 meeting. So that particular agenda always starts out with hospital capacity and the hospital capacity report. And as you can see from that report, there are two particular items that may stand out, and that is the ICU beds available in Havasu Regional Medical Center and in Valley View. I always want to stress and point out the fact that these hospitals, while their capacity looks like they don't have any beds or they have very limited beds available, that capacity can be scaled up and scaled down, and that they are in a position to do so. Secondly, talking about personal protective equipment, we continue to receive requests, although far fewer, from agencies. And so we continue also to try to secure and procure some of those items for distribution out in the community. And I think everybody's in the same boat. There's still, the supply chain is opening up, but very, very slowly. So we'll continue to look for those supplies for Mojave County so that we can distribute them out, but also all of our partners are expected to follow through with their own supply chains as they may be different than ours. The case numbers, we always monitor San Bernardino County, particularly Needles and Laughlin. In both cases, Needles shows 0 cases still, and in Laughlin, there are fewer than 5. So still working off that. Supervisor Johnson asked about hospital testing capacity and whether or not there were any scheduled testing blitz events for the extension through May. So far, there are no events scheduled, and in reaching out to Sonora Quest, they do not have any planned events, testing blitz events scheduled at this time. Additionally, what I learned from the hospitals is that they do have the testing supplies that they need for their staff. In some cases, for those that actually perform testing on first responders, they have it for that population and for their admits and surgeries. But to do any community level testing would deplete their testing supplies pretty significantly. And so at this point, they do not have any plans to move forward with community-based testing, such as the testing blitz event. Let's see. From there, unless there's questions, I'm certainly happy to answer questions before I move on to the actual testing presentation, or the test and data presentation.
Any questions from anyone?
Madam Chair, I have a
Supervisor
couple
Angus.
of questions.
Sure.
Talking about hospital testing, so I had a constituent call this morning, and this person works for a hospital, and they had a COVID patient that had been in the hospital before this person was tested, and she was the nurse for this patient, and then the patient was diagnosed COVID positive. Is there some sort of policy? Do the healthcare workers automatically get tested? Is it just up to the hospital because they're not being the healthcare people are not being tested?
I'm not familiar with all of the hospital policies to know if that's something that they have as a policy or practice. I do know that they are using some of those testing supplies that they have on hand to test some of their staff, but I'm not familiar with each of the hospitals and what protocols they're using and that decision tree basically of how they're choosing to determine whether or not to test their staff.
But it's not a policy by Arizona Department of Health. They're not saying, I mean, it seems like it should be. So if it's entered into a hospital and healthcare workers were exposed, it seems that it should be up to the hospital to immediately test them just to protect future patients.
Certainly.
But
And
you're
I know
saying that that's not something the state requires.
they may very well have those protocols in place, and I'm just not familiar with their practices and what ADHS has directed them to do.
Can you find out?
I can.
That would be great. Is this a time to talk about reporting, or is that something you want after the presentation?
I think it would be helpful after the presentation, if you don't mind.
That's fine, thank
Okay.
you.
All right. Sorry, I'm going to just write a note to myself to make sure I follow up with that question. All right, so we'll go through the presentation. And this is really to talk a little bit about the data stream. Where does the data come from? How is it entered? What's the process for determining confirmed and probable? And I'm going to start this process, but Mayor will probably interject as we get into some of the more technical information. I am not an epidemiologist, nor do I proclaim to be, and I feel like they can better address questions from the board and also some of the presentation pieces better than I. So I'd like them to very much jump in when they can. So let me get my clicker. All right. So MedSys, you hear me talk a lot about MedSys, and MedSys is a secure database that holds information about all cases of communicable disease. So there are about 90 reportable diseases now, and what a case is a disease for a person. A single person can be 2 or 3 cases of different diseases even in a given year. So did I confuse you all? Hopefully not. Okay. All right. Okay, new cases are reported in MedSys by doctors, laboratories, public health throughout the day and into the evening. It's pretty much a 24-hour operation. As you may remember, initially when COVID testing first started through the state lab, they were batching 1 test per day. And so it was taking some time, some turnaround time, up to 10 to 14 days to get test results back. That capacity has increased substantially. We have onboarded, not personally, but ADHS has onboarded commercial laboratories into this process, so that's expanded capacity considerably. And in that case, it's now around the clock, those testing. The nursing and the epi staff look at every single report for Mojave County, and oftentimes the nurses will learn something new about a case and enter that information or change the information in MedSys because they want that information to be accurate. So as they learn that, they'll input that information. Make sure I push the right button. So this is how staff classify a case as confirmed or probable. This is the algorithm that's used to do this. So if I could have Mayor basically go through this algorithm, because she and Anna certainly and some of the other staff do this on a daily basis, that would be really helpful. Mayor, are you available?
Yes, absolutely. So this, we're going to go to the next slide so that you can see an example close up, because that one's pretty convoluted. So if you could go to the next slide, it's one way we can look at a test.
Okay, it's done.
So the simplest thing is if a person gets an appropriate test for COVID and it comes back that COVID is detected or positive, then they are a confirmed case. You're very familiar with those. How do we get a probable case? Well, there are a number of ways, as you can see on that other chart. And I do want to emphasize, we didn't make up that chart. That is handed down to us from CDC and the State Department of Health. So we have to use that as our guidance. So let's take a look at somebody who has not had a test. If it's a death and COVID was listed as a significant condition, that's that top gray box, then they become a probable case that is a probable COVID death. But now let's go on to if they didn't die, they're alive. And if the patient had any of those symptoms, any of those combinations you see there. So they had to have had at least one of the big three: cough, shortness of breath, difficulty breathing. Have to be in there, and there's no other likely diagnosis. So in other words, the person doesn't have bronchitis or allergies or no other diagnosis. Then we find out additional information about them and their symptoms, and one thing we check is, was this person in contact with someone who we know to have COVID? And if so, you follow that left stream down to the left, and they become a probable. There also can be, as you see kind of on the right side of that stream going down, if they've had an antibody test and there's a yes or detected, then they would be a probable, and if it's not a case. So as you saw from the bigger chart, there are many ways you can get to a probable case, but there have to be a number of elements there in order for it to become probable. Here at Mojave, because we have so few of us, we haven't spent that much time looking for probable cases. We've just used confirmed as our main guidance, but we have had some probables come in for various reasons. So we have about 6 probable cases in our records right now of all the cases, and 2 of those died and 4 of those survived. So that's where we are, and that's how we determine it.
Okay. Supervisor Angus, did you want to?
I don't understand, why don't they just get tested? If they're the ones that at least survive, I mean, first of all, can you test after death? I mean, why aren't they testing?
Right. So there have been a few contributing factors to that. One of them is that we don't have enough tests. And so the state and the CDC has prioritized those for certain people, for instance, who we might be able to save, and so we want to test them now so we can treat them properly, for example. Or for people, you mentioned earlier, hospital workers or long-term care facilities, try to prioritize those. So if we had tests for everybody, we could. And then sometimes the reason why they haven't tested is because they didn't know until after the autopsy was done or other information until they finished that. But again, that's pretty rare, so we only have a handful of those.
Whenever I hear that we don't have enough tests, and then I think in the last 3 weeks we have used about 1,000 tests through SonoraQuest for people who just were getting them for the sake of getting them. I mean, is there any priority set to say, okay, we have this number of tests in Arizona? I mean, I can't be the only one thinking like this.
Yes, I'm not sure about the procurement chain, about how SonoraQuest procured all of those test kits, because essentially they had 500 test kits ready for each event. But we continue to see that supply chain fairly limited for the hospitals. And I'm not certain of the reason. I've been reaching out to those particular hospital CEOs and my contacts there, and that is they continue to struggle to find those testing supplies.
Do we help them with that?
When we can, but we're also in a limited basis. I mean, we do get some test kits from the Arizona Department of Health Services, and we utilize those or distribute them out. But they're also very limited. To open it up to the public would be, you'd need quite a few kits, at that rate.
Madam Chair.
Supervisor Johnson, go ahead.
Thank you, Madam Chair. When you're talking about probable cases, could that mean that all these people, who are, I guess, in the hundreds by now, that have been sent home from the hospitals without tests and told to quarantine for 14 days and obviously weren't tested, those could have been positive, so our numbers really don't seem to be meaning a lot?
Mayor, could
I
you?
wouldn't say they don't mean a lot, but I would say that my estimate would be that we've missed quite a few probables. But your point, actually, the way you described that is exactly why. Because as long as we get somebody into quarantine and we think they're probably a probable case, we're doing our disease control job. So we're not so worried about them getting a test as we are about getting them in quarantine.
I understand that, but it skewers the numbers really bad both ways. One way that we had a lot more cases, or possibly could have had a lot more cases, and that we could have had a lot more recoveries that we could have reported.
Very possible.
Yes. Yeah. And I think initially the real testing supply shortage really drove that process. As you know, a lot of people were sent home to quarantine without tests because there was such a limited supply of testing materials.
So Denise, it all boils down to the fact that there's just not enough tests out there in order to test everybody, and so we're just trying to limit exposure and keep everybody as safe as we can without doing a test on every suspected person that becomes ill.
Correct.
Okay.
I mean, knowing that the testing supply chain is still very limited, we have to really prioritize those test kits and the use of those test kits. And so that's what hospitals have done and healthcare providers.
And so with Supervisor
Madam Chair.
Angus's comment that Sonora Quest was able to put out 1,500 test kits, that doesn't really make sense, because if they're so limited in testing for all the medical providers, why did Sonora Quest get so many
Give to relatively healthy people.
tests to just give to anybody that wants them? Was that a way or a means for the state government to show that testing is available?
Well, I think the goal was to increase testing, at least for that time, in our community, and it worked, right? I mean, you saw an increase in the number of tests performed in our county and throughout the entire state, for that matter, and they achieved that goal of increasing testing. But it is a snapshot in time, of course. The results of that are a snapshot in time, so.
Okay, I think that's a good explanation, just a snapshot in time. Okay, Supervisor Johnson.
Thank you, Madam Chair. I think those 500 tests that were given were basically ridiculous and just skewered our numbers because there was no standards. It's just like saying, okay, you've got 5 people sitting up there on the board today, and we're all going to give them tests on whatever, cross-eyed. Well, maybe nobody's cross-eyed up there, so why even give them a test if they don't show any signs of it? And here we're testing people and saying, hey, these people didn't have it. Well, if they never showed the symptoms, that really doesn't make any sense. And I guess when we're talking about now the shortages you're seeing in the hospitals, it is really bothering me, because if we have a shortage, you would think it would be needed for the people who maybe show the symptoms so they can be treated, but the hospitals seem to be running shortages because they're testing everyone who's coming in for elective surgeries. So that's what's bothering me now. We're going to see, or possibly see, more people being sent home to quarantine without being tested because they're hoarding the tests for their own people, for their own profits. Would that be correct?
Well, I think you make a good point, Supervisor Johnson. I think the distinction is that the hospitals have the testing supplies that they need for their internal needs, but not necessarily to test further out into the community. So to do anything beyond their own organizational needs, would be difficult because the number of testing supplies that would be needed to accomplish that would be much greater.
Well, I agree partly with that, but I would think that now, because the report you give us shows their testing supplies and things are getting short now, that they would have a greater tendency just to send people home to quarantine instead of testing them to see if they had the virus, because they need those supplies for their own needs.
Right. I mean, they're definitely trying to meet their organizational needs, which includes their own healthcare staff, if needed, and any admits into the hospital, certainly before surgeries as required by ADHS as far as the elective surgeries. So there are very specific reasons why they maintain a certain supply of those test kits for their internal agency.
And so I would guess it might be good for us to try to acquire tests that we could be given to the hospitals, but those tests could only be given to people who come in and show symptoms and not be used for their own personal needs. I mean, because we're trying to put together numbers so that people know there is a problem or there isn't a problem, and to open up our county. And without those numbers, we're pretty much just flailing around.
Well, I think it paints a more clear picture, certainly, if we have an increased number of tests performed on a long-term basis, on an ongoing basis, for sure.
Okay.
Mayor or Anna, did you want to add anything to that? Okay, all right.
Sure.
Okay.
This is Anna. And what I would point out is that the role with the epidemiology and what we're doing in terms of public health isn't necessarily to identify every single case that's in the community, but to really drive home the trends and the patterns that we do see in the reports we do have. And so that's kind of one of the distinctions. We'll never be able to glean out and find every single case that's out there. What we need to do is work with what we do have at hand and look into that information that we do have and look for the important trends and the patterns in there.
Madam Chair?
Supervisor Johnson?
Thank you, Madam Chair. I don't want to beat this dead horse anymore, but most of us that are sitting here today would probably opt not to go to the hospital if we had partial symptoms, because we don't want to make sure we get it when we go to the hospital. So I'm thinking limited numbers of people show up at the hospital for testing because they're showing conditions that are the same as the illness, and they want to be tested, and we're turning those people away. So I think the ones that even show up are a small percentage of the people who possibly could have been getting it. That's all, Madam Chair.
Okay. Supervisor Angus?
I just want some clarification, because we see a lot in the reports about probably the majority of these newer cases are connected to already confirmed
Linked to another.
cases. So let's say that, my husband has it, and in your investigation, can I request a test because, I live with him, or do I have to be symptomatic before I get it? I mean, I guess my question, are all of these people symptomatic that are testing positive, or are they asymptomatic?
Good question. Anna or Mayor, do you know the answer to that?
Madam
Sure.
Chair and Supervisors, most of them are symptomatic because that is often a requirement that we have. But there are some who are asymptomatic or very minimal, but it's mostly symptoms. Anna, do you want to add to that?
Yes, the tests that are available right now mostly are out there for symptomatic folks. So, indeed, if you go to the hospital, if you go to a healthcare provider, the best testing is going to be for the symptomatic folks. There are ways that you can get tested, such as these blitz events, if you're curious or if you're asymptomatic and you think you might have it. So that was part of the purpose of some of those blitz events.
Any other questions?
Madam Chairman,
Yes, go ahead.
the main reason for the blitz testing was to run down run up the test numbers and run down the found cases so that the governor could meet the White House gating to open the state back up. Let me crack that code for you. Thank you.
Okay, Supervisor Angus.
Thank you very much, Supervisor Gould. And just as a policy for the board, that's something we can do. I just really do feel uncomfortable putting the probable deaths, because when people come to our dashboard, with everything that's going on in the country, I feel confident with the numbers here. It's the only place I feel confident is Mojave County, honestly. But when you start putting in these probables and into the mix, and then, let's just be honest, there's some monetary incentive to it now. So at the very least, can we have another designation saying for probables, just keep the deaths. These are people who have confirmed, 100% confirmed, and they died. And these are people, even the ones that are recovering, we should have it out of the confirmed ones. I just think that makes it cleaner, and it makes people feel comfortable that they trust our numbers, because I think at this point, that is one of the most important things for our citizens, is to be able to trust the numbers as they decide whether to open up and go back to work and do all those things that we want them to do.
So Denise, one of the reasons that we started tracking probable deaths is because the board asked you to make our numbers match the ADHS numbers that they're reporting, so that people aren't confused with the different numbers.
Correct.
So can you tell us what's important for us to have on our hub that allows us to make these decisions?
Well, Supervisor Angus, I certainly understand the accuracy part. I mean, for us, that is very important, and credibility is a big piece of that, of where people go and knowing that the information on our website, albeit different, possibly is different for a very concrete reason that we can explain and help people understand. And so those are all big questions of whether or not we match or don't match. And it's just recently that the Arizona Department of Health Services has started including both probable deaths and probable cases. So as Mayor mentioned, we don't have many of those. They are currently not on our dashboard. You will see them in your reports. We've started including them in the daily reports that we provide to you, but in terms of what you see on our dashboard, those are pure confirmed cases that we know about. So I guess that's where we're looking for some guidance from all of you. When it comes to your constituents, I suppose, and yourselves, what are you comfortable with in terms of the data? Are you more comfortable with our numbers matching the Arizona Department of Health Services dashboard? Because people are going to both, and when they see discrepancies, it is a question that comes up, and sometimes even when we have an opportunity to answer that question, it still causes angst, if you will, among people of going, well, why are their numbers different than these numbers? They want some consistency, so we're trying to provide that, and we've tried in the last 2 weeks really to develop systems where we can provide you that real-time data to the degree that we can, but also looking at the accuracy and matching piece, right?
Right.
But I guess we're looking for some direction really from the board in terms of some concrete direction to go, to say this is what we're going to do, this is what we'll show. If we're going to deviate in some way from our interpretation and put different case numbers, because we're only going to stay with confirmed, for example, then we can do that and just put an explanation underneath that says these are only confirmed cases, this is why it differs from ADHS. Or we could break it out by probables and confirmed. It's just more information on our dashboard. We want to try to keep that as simple and streamlined as we can also, and make sure that we keep the readability of that, to be effective for the general public.
Denise, in my personal opinion, probable sounds very close to guesswork. I mean, I know it's more than that because you have to identify the symptoms and everything, but...
You've seen the algorithm, so you understand completely the process that goes into it, but yes.
Exactly, but a layperson looks at that, what do you mean probable? They're either sick or they're not, and I keep hearing, just tell us the truth, like we're hiding things because things aren't matching up. If they get their pencil and yellow pad together and start adding these numbers and comparing them to the state and everything. So I really don't know what the answer is, other than to just keep reporting the factual information that we have. So does anyone have any idea what we're reporting? Do we need to add to it or take away? Supervisor Watson.
Are you suggesting that possibly there are some counties in the United States that not be reporting this correctly, such as Cook County, Illinois, which there's a possibility that where patients that had head trauma from vehicle traffic and stab wounds and bullet holes that also contracted the virus have been counted as victims of the virus?
Exactly, and I don't know if it's true or not, but I'm hearing in different media sources that hospitals get paid an exorbitant amount of money if their patients are reported to have COVID, even though they may have died from other complications. They put COVID on the death certificate because they get more money. So,
well, I was a little bit tongue-in-cheek when I was saying about head trauma, stab wounds, and gunshot wounds, but I think it does bring a point to the conversation that if a person had a heart issue, if they were to contract the COVID-19 virus and expire, how is it listed? Is it listed by expiry by the COVID virus, or if the person had a heart attack and died? That's kind of a tough question to answer, I would suppose. Mm-hmm. But it's probably mixed into the numbers. People with pulmonary diseases that come in with pulmonary problems exacerbated by COVID-19, I would suppose you could point to that particular case and say, well, yes, that person did expire from COVID-19, but they did come in with pulmonary problems prior to that. So it's going to be very difficult for us to separate those numbers. I suppose the best way to do it is to accept the numbers as best described by the medical profession and trust those people making those decisions. Just a thought.
Madam Chair and Supervisors, this is Mayor, and I've looked into this a little bit. I don't know how they do it at Cook County, so I can't speak to that. I do know that if a hospital says that a patient has COVID for their records or for whatever, we do not count it as a case unless it meets the requirements you see on this algorithm. So they might call something a COVID, and if they get money for it, again, I don't know. But we're not counting it just because they coded it that way at the hospital. We have to have the other evidence.
okay, that explains it. Thank you. Thank you. I appreciate that bit of information.
So to answer your question about direction, right now you're saying we're getting that information, but it's not on the public dashboard?
Correct. Correct. We have not added that in because we wanted to have this conversation first
Right.
to understand before that was public
Honestly, I
facing.
think that's the way it should stay. If you have to have an asterisk or something to explain it, if we can maybe put it into our press releases that, that Mojave County is only reporting the 100% confirmed COVID cases. So that might cover if there's a discrepancy. People could, infer what that means. That's my opinion.
Okay. Does anybody else have any
Madam Chair?
thoughts? Yes, go ahead.
Yeah, my only thing would be on the probable cases, we could list those with the doctor's name saying they're too lazy to do their job.
Thank you, Supervisor Johnson. Supervisor Gold, do you have any input?
None today, ma'am.
Okay. Does that answer your question, Denise?
It does. Confirmed is where we go.
Okay, while we're on that subject, I'd like to ask you about our news releases. We get a news release in the morning, and we get a news release in the evening. And during that 8 or 12-hour period, typically I don't see anything changing, so it seems to be a duplication in the morning at least, because you're reporting the numbers in the evening, and then when our PIO wakes up in the morning, he pretty much sends us the same information.
Right.
Can we reduce that to one a day, do you think, in your opinion?
Well, yes. I mean, I think we can. I guess the question really is, you all receive in the evening more granular data. And how important is that to the board? Because that granular data is reported in the next day when you see that daily report that you receive in your inbox. That is wrapped up into that report and those numbers and that information. So what we're trying to really do is streamline our process and realizing that we're going to go back to and move towards normalizing our own operations for the community's benefit, which means we will have some nursing staff step away to do immunization clinics and so on, and that's our core group of people. That's part of our core team. So to that end, we're just trying to look at streamlining the reporting process to be able to give you the information that you need, but really looking at what's important to know. Is it more important for you all to know the trends of how things are rolling versus an individual case information? So if we didn't have to provide the evening report that you all get, then you would absolutely get the report the following day, of course, and that would include those cases from the day before.
Okay, any thoughts on that? Okay, hearing none, I think we could go with just one report.
Okay. And what we can do is develop that report in such a way that maybe that's what we can use with Roger and the communications director as far as the press release.
Exactly.
So that would give, now that our numbers are much higher, it gives, it can paint a whole different picture. People can be looking at the data differently, and hopefully that difference makes it more impactful to them.
Yeah, I think that's the difference, is now that we're, 250 numbers, and we can look at it a little bit differently and downsize our reporting just slightly.
Okay.
Okay, does anybody have any problems with that?
Are you going to put it in the form of a motion?
We can do that.
Madam Chair, I make a motion that we go to one report a day. Do I need to do anything more than that?
And one report / news release?
All right, one report and one news release.
Okay.
Question.
Okay, Supervisor Watson, go ahead.
Would that report be the PM report, which would collect the data for the entire day?
Would that be your recommendation, the evening report, or would it be better to do the morning report?
My initial thought is, we can certainly talk through this, my initial thought is the morning report, only because it will capture the previous day's information. It will be the most complete.
Fine with me.
What we've been providing you in the evening really is just a snapshot of a day.
Okay.
And so we'll be rolling that information in and getting that information to you the following day.
Fine.
Okay.
Just wanted a clarification. Thank you.
Okay.
And I'll second the motion.
All right, Supervisor Johnson, did you have something?
Yes, thank you, Madam Chair. So will the evening report now include the 2 updates you give us from your staff, or are those still going to continue?
Supervisor Johnson, I think we were eliminating that evening report and going to an overall morning report.
So we'll have 2 reports, a morning report and an evening report? Or not, the evening report's usually the press release on cases for the day.
Correct, correct. So what we'd like to do is develop, and we have a template for, based off the report that you all receive in the morning, is using something similar to that we can report out each day. And that will give people, you'll be able to see trending information that way, cases per week. And we can include the zip code level data in that as well, so people can look by zip code a little bit more easily than going to the ADHS website. But keeping in mind, that's another really important distinction here, and Mayor may need to jump in here. She did learn a little bit more about zip codes and why our zip code data does not match ADHS. And that's, Mayor, you want to jump in?
Absolutely. Madam Chair and Supervisors, I'll do the best I can to describe this. I was speaking with the person who does the zip coding at the Arizona Department of Health Services. So what I learned was that many zip codes cannot be mapped to an actual area on a map. 1/3 of all zip codes are what they call non-area zip codes. And since ADHS, the state, is doing their report based on the latitude and longitude of where the person lives, if they live in one of those non-area zip codes, it does not get reported there. It gets reported where the nearest post office is. And what he explained to me is that zip code areas that you see if you go online and ask for them, those were created by businesses and other places that just wanted to map out areas, but it does not fit with how they can assign a zip code. So that means that if we really do want to look at zip code areas as we understand them, we want to use the zip code that we have in our records, which we can give you in a table.
That is a home zip code.
That's interesting. Attitude and longitude.
I know.
We are learning a lot through this
I
process.
know. I was fascinated, but yeah, I said the same thing. And so that's why you're seeing 0 in some of the zip codes that they have on their map, because those are the could be one of the non-area zip codes. And so nothing gets sent there. Nothing gets coded there.
Right. And we did remove the PO box, was that 86402?
Yes,
We did
I
remove that
noticed
from there
that.
because there are no cases assigned to that area.
Right. Well, I believe my constituents, anyway, would like to see the zip codes reported as we have been doing that, because
Yes.
it connects closer to where they actually live.
Correct. So, in that case, looking at that report that we provide to you, those are pieces that we can put in there that will make it a more clear snapshot every day for people to be able to look at case numbers and relate to that information better, I believe.
Okay. Any other comments? We have a motion on the floor and a second. Supervisor Johnson, go ahead.
I'm still a little confused. We get the COVID-19 report in the morning and then a GIF report, and then we get the press release in the evening on the cases. What exactly are we getting rid of, or what are we combining?
So Supervisor Johnson, as I understand it, we would move to only provide the report in the morning, and then that same report will be also used, modified slightly, because right now we include the testing numbers, which is just, and maybe this is a good point to bring up also. So we provide those testing numbers for the board, as you see, like the final, 2 pages maybe of the report each day. And as you know, those numbers are only hospital numbers that are provided to us, and North Country Healthcare provides those numbers to us, and that is only once per week. So you can see that it's an incomplete picture of the total testing that goes on, and that number is probably more representative on the Arizona Department of Health Services website. So we've been using ADHS numbers there because that includes all the private providers that are testing, it includes all the small clinics that may be testing, and so on. So we could modify that report to not include the testing numbers, but the rest of that would remain the same, and that could go out to the public as well on a daily basis and be available on our webpage, just as an attachment. I don't know that we'd want it to be the front page, but certainly we could provide that on a daily basis so that people would have that available to look through and review.
So you're going to make us do all the work of looking at ADHS to get the complete numbers?
No, sir. We would provide you, so looking at the daily report that you receive in the morning, so that is an aggregate of all of the cases that we have on record of COVID-19. And we would provide that to you in the morning, and then we would also modify that just slightly for the communications director to send out to the media so that they can have that information on a daily basis. So that what you wouldn't be receiving as of now would be that case-by-case count that you get at the end of a day. Did I answer your question, Supervisor Johnson, or?
No, you've got me totally confused.
Okay.
Madam Chair? But we
Supervisor
still
Angus, go
get
ahead.
that report that comes from our lawyer about, breaking it down.
Well, that's the question. If we want to continue sending that, we can. That, and maybe what we do is just send the report that we provide you in the morning, the modified report without the testing portion in it, out through to the media each day, because that's really showing the trends. That's really showing a bigger picture, kind of more of a 10,000-foot view of it rather than the 10-foot view that you get really at the end of each day.
All right, so I think maybe I now don't understand this. See, if we go with what I just made a motion to, we wouldn't get that information that we get from our legal office about.
Denise, would it help if you put these up on the screen for everybody?
Well, the ones that
these
I'm
are the
talking about aren't public.
reports, like this one, and
Let me take a look.
these are the ones that I printed out, and maybe that will help clarify somewhat. Okay.
All right. Here we go. Okay. All right, so currently you receive a report of this nature every morning, Monday through Friday, and this gives you an aggregated total of the cases that we've encountered, as well as the disposition, and you can see the trends by week, et cetera. So that would continue. The question, as your motion put it, I don't know that it included the evening case piece, where we break out each case for you and then provide that granular level of detail again. So
That's the one from the attorney.
right. And here's one consideration, and Anna, and I might need some help from Anna or Mayor on this one, but because they have a lot more experience with MedSys, is some of that information, it requires staff to go in and actually read through the notes to gain that information to put it into the report. And it takes time to do that. So when we have large numbers of case counts, for example, that can take up to, I know it's taken Lynn up to a couple of hours to write out that report. I know it seems very simple, but to gather that information requires going into that system and collecting it and then reporting it out. So Mayor, Anna, can you help me out? Is that accurate?
This is Mayor. Yes, that's right.
Oh,
Madam Chair?
One second, Supervisor Johnson. That's the report that I actually get the most out of.
Okay, okay. And that's what I
I'm
was asking.
sorry it takes, all that time, but that's the one I really examine every day and, get the, the most out of. I'm not saying that, I can switch and maybe look at the other ones more
Right.
and get the same thing, but I would like that to continue.
Okay, and that's fine. We can absolutely do that. That's not a problem.
Better change the motion.
Yes, and so if it's okay, can we, rather than doing a press release off that information each day, could we shift to providing information from this daily report here every day? So it's, again, more of an aggregate picture, a bigger picture of what's going on in our community, and not just a case-by-case example.
Is there a place that you can make up the time? Because I know it's labor intensive, I get it. And that's probably one of the reasons. I know you guys are busy. Is there like another area you can save time on that we can give you?
Well, Anna, Mayor, since they're my data people, any thoughts?
Well, as you said, Denise, we're trying to streamline as much as possible. I know one thing that would help with that report is if we could just decide on a few things that you want in it so that Lynn doesn't have to go through all the fields. Is mostly what you're using, the gender and age? What's the most important things you get from the lawyer report?
Right. That's what I look for, the gender and the age.
Okay.
So not that they're recovering at home or in the hospital, and that's not,
Yeah, well, that too. That's why I like that report so much. It really gives me that daily view of
right.
where we're at.
Right, right.
But that's me. I'll whatever the board wishes.
Okay.
Supervisor.
Madam Chairman?
Madam Chair, thank you. I believe my redneck may be showing here a little bit, but I believe the one report that we received that has the graphical analysis, it might be better identified as the previous number of hours or the previous day cutoff date. And as I recall, I don't know that that's listed as a cutoff.
The 5 o'clock.
5 o'clock the previous day. Is that,
Well, it's
isn't that correct?
up to 5 o'clock that day. So what you've been receiving has been, so when we send out those reports, like at 5:30, they're about 6 o'clock sometimes, that's up to 5 o'clock that day.
Okay, I've been
Same
getting
day.
those in the morning, but that's fine.
Oh, so these reports here are
What
provided.
you're calling the granular data,
Yeah.
we're receiving in the evening,
Yes,
which I think both reports are necessary in order for us to get a complete picture of what's occurring. So I'll withdraw my motion, or my
Yeah,
second.
I'll withdraw my motion.
Okay.
And I think in order to make it simple, we do need both reports.
okay.
Okay. Supervisor Johnson?
I'm happy now. Supervisor Gould had a question, though.
Okay. Supervisor Gold, go ahead.
Thank you, Madam Chairman. I find the lawyer report useful and would like that to continue. I'm also concerned that if we don't put a press release out in the evening, that the public might not find out those numbers for 2 days by the time they get in the newspaper.
Is that more a matter of how frequently the papers come out Supervisor Gould? The timing of the paper, because we would then post that information or send it through the communications director to the newspaper the following day, the following morning.
I'm not sure if we're already missing the cutoff to make the paper that evening.
We are. I believe the cutoff, generally speaking, is about 2:30 in the afternoon for the newspapers. At least my experience with the communication director is that it's been about 2:30 for the next.
So the public is already getting 2-day-old data then?
At that point.
I guess it doesn't make, if we're already missing their cutoff, I guess it doesn't make any difference whether we put the presser out at night or in the morning.
Thoughts?
Well, going back to the initial conversation was the news release in the evening and the news release in the morning appears to not change for the majority of the news releases recently. So
Right.
I think one of those news releases can be eliminated without harming the information to the public or to the board.
So right now, we have just the evening report going to the communications director and out to the media. The option for newspapers at that point would be to use their online resources, not their print resources there, so they could post the information online. I'm not familiar with whether or not they take that step and add it, or whether or not it posts for them the next day.
Okay, I might have misspoken. Maybe it's not two news releases. It's the news release and then the daily update seems to be a duplication.
The news release contains the information that you receive in the evening.
Right.
So, and it sort of, it breaks it down, and I don't have one in front of me, I'm sorry, but it provides kind of the daily account of the cases. And what I'm thinking may be more useful to the public, really, on that scale, is to look at the graphs and the charts and things on a larger scale. I think that paints a different picture of our cases and our counts, rather than it being on an individual count. So I can see where we can still continue to give you, I'm sorry, Supervisor Watson, I didn't mean to interrupt, but we can continue to give you your daily report in the evening that you've gotten, but maybe move to something of this nature that I'm showing right now, something of that sort, where we can do that on a daily basis out to the media.
Okay, Supervisor Watson?
Madam Chairman, if we keep beating this horse, my arm's going to get tired. Now, you can call me Bubba if you'd want to, and that'd be fine with me, but I think what we're offering the public and what we're offering those that are in the news media is sufficient enough for them to have the reporting. And so if we go beyond this, we're going to start confusing people, I believe. So as long as we stay with the two reports, the one that we receive in the morning, recapitalization of the granular information at night, I think that would be sufficient for those in the news industry to make their analysis and their reports. With that, thank you.
I agree with the confusion, because I think we're confused now just discussing it. So.
I know. Hence the reason we're here, right? Because if you can imagine, we're just trying to get that clear direction from the board on what you think is most important to move forward, and those are the reports that we will provide.
Okay.
Phew, right? All right.
Do we still need a motion?
So I know your time is limited here, so
I don't believe we need a motion because there's no change in operation.
No change, then no, we need no motion.
okay. All right. Thank you. All right. And I may send you all an email to clarify, just to make sure I have it all accurate, okay?
Okay.
So if you could all just respond, that would be awesome.
No, don't all respond, okay?
Oh, I'm sorry. Thank you.
Yeah,
Thank you for keeping that.
so don't respond. And I
Yes.
think we've got it clear. Just keep it as you currently are standing.
Okay, all right, can do. All right, so the next part of this is to talk about what occurs on a nurse and EPI's day. So, Mayor, do you want to kind of take it on this one?
Sure. So what's happening now, and Denise already mentioned that we've got to start moving some of the nurses off of COVID and working on some other things, such as vaccinations for school. So we actually have fewer people to work on cases and contacts and quarantining than we did before. We're especially concerned about this because there's going to be a big push on tests in long-term care facilities from the state health department, and so when they identify staff, we're going to need to quarantine and follow staff, just so you know, we're kind of planning for that in the future. So here's a typical one of our day. Take a call from a nursing home asking about how to cohort residents with COVID, or asking maybe to have somebody tested if they're showing symptoms. Then you review some lab information and enter it into MedSys. We interview cases, we call them, find out what their symptoms are, and collect information on them so that we can then monitor them for the next few weeks and help them decide when they can come out of quarantine. We have to take swabs or nasopharyngeal swabs now to do tests. So when we do rapid tests, we have to get a swab, and then if we retest, we have to get a nasopharyngeal swab. We're always having to review the new rules on how long to isolate and quarantine cases. So it's kind of like being a doctor and keeping up with all the latest medical news. We're always fielding calls, like somebody will call and say, hey, I'm in quarantine, I need a letter from my supervisor, we have to get that out. Then we might get a call from the supervisor saying, did you say that my employee has to quarantine? We get on conference calls with the Arizona Department of Health Services so we can find out what the new testing rules are. I just wanted to kind of paint a picture of the breadth of what everyone's doing every day.
All right, thank you. All right.
Madam Chair,
Yes, Supervisor Johnson.
maybe they can clarify about all this testing they're doing. I thought we only had 25 tests that we could perform.
Are you referring to the rapid tests?
Well, the person that was just giving the speech was acting like we're doing tests all day long, and I thought we only had those 25 rapid tests.
Right.
What tests are we giving for COVID if we don't have any tests?
We did receive some additional rapid test kits from the Arizona Department of Health Services. We did request additional almost immediately after receiving the machine, just on a hunch, if you will, a guess that we would need more. And so we did receive more of those kits, which we have been using specifically and only in long-term care facilities.
How many of those did you receive?
Good question. I don't have that number at the moment, but I will find out that number for you, Supervisor Johnson.
And this
Yes,
is Mayor, I may be able to get it while we're talking.
Okay, thanks, Mayor. Okay.
It's my understanding that those tests have been questioned if they're accurate or not. Is that true?
That is true. It's the negative tests primarily that are questionable. And so at this point in time, if we get a negative test, we actually retest them through the NP swabs, and then those test kits are sent down to the Arizona State Lab. Yes. Any other questions on the test kits?
Not that I see.
Okay, all right. So the Arizona Department of Health Services will also enter information into MedSys. They'll create new codes based on new information and update the information in MedSys there. the resulting data that we get from MedSys, we have name, age, gender, diagnosis date, et cetera. You can see the slide there. So that's all the information that we would have in that setting, whether or not they're in a congregate setting, close contacts of cases. So that's how we track that information. And epidemiology work is really always adapting because they can't control the environment or the people we study. That's part of how it works and just their process. So I don't know that we need to go into this data necessarily because I believe we've sort of covered it in our conversation that we had earlier, but it really just defines that case information again. What we were doing was that 5 o'clock, after 5 o'clock, we get the case counts. It's a snapshot of every day. These are only people who have a permanent address, residence in Mojave County, because that's how they are assigned to us. And the cases are classified as confirmed or probable in that system. So again, this just kind of goes through some of these other questions that we've already addressed in our previous discussion. So if you don't mind, I kind of scan through this for time's sake. Is that all right?
Yep.
Okay.
And Madam Chair, sorry, real quick. I did forward this presentation to all of you, so you do have it to refer back to.
Okay, thank you.
So why don't the total number of cases add up to the single case reports that we get each day? There are a few reasons that come up and a few reasons why we have to occasionally change the data. There are new cases added, which we already know. Staff may find a duplicate case and delete one. A case assigned to Mojave County actually may live in California, and therefore it's transferred out of our jurisdiction. A new test result that show that a person's test was incorrectly entered as positive by the laboratory, so we correct that, and that's why we review all the lab results. And a new test that shows that a probable case is now a confirmed case, that they may have had a confirmatory test come back and a result there. So there's a variety of reasons why data doesn't always match, as much as we try. And I think where we're going is really just trying to use the data in its aggregate form for decision-making about where our prevention activities should focus, whether or not that's on long-term care facilities and working more closely with them, whether or not that's looking at certain age groups and trying to provide more preventive information and education out in the community to have a bigger impact. And looking at those trends over time, we're looking at analysis by age, gender, to target the most vulnerable. Anyway, so those are all just other options of ways that we can look at data, I think, that will hopefully provide a bigger picture view, as we've mentioned before, about how we approach our public health work, and not just on an individual level. That is a big portion of our job at the moment, but I think moving forward, it's about messaging and trying to get information out to the public about how to continue to use those preventive measures. Any other questions? Okay.
No questions.
I apologize for my telephone going off. I didn't realize I didn't have it on mute.
Okay, I didn't have any other updates to provide at the time. I think I've taken up a lot of your time. I appreciate you giving us the opportunity to talk about all of this, because it really, it's very complicated, but it's also very important. And that's really what it's about.
Okay, last chance for any questions.
I have questions, Madam Chair.
Supervisor Johnson, go ahead.
Okay. Looking for my notes here. You made the statement that the hospitals can expand, not because a lot of them are saying they have no space. Let's say they get a positive COVID case. Obviously, that person would have to be segregated from all the people that are getting elective surgery in the ICU. How quick can they set these additional hospital spaces up they keep talking about?
Very good question, Supervisor Johnson. I'm not sure what their time frame is to staff up. Most of them have already designated the space or know what that space is going to look like. So I'm assuming that they can rapidly move to adjust their staffing capacity to meet the need.
Rapidly move, does that mean 15 minutes, an hour, 2 days?
I'd need to get with the hospitals to learn about how quickly they could make that adjustment and surge.
We continue to get complaints about the opening of bars. Now, the governor's order was kind of vague on bars and restaurants, but restaurants, he was fairly clear on limited capacity and the steps that they had to take. Bars seem to be trying to get around the restriction by saying, oh, we're serving popcorn. What requirements are required of, let's just say, bar facilities, or should they be following? Should their people be wearing masks that are working there? Are they still supposed to be at a lower capacity?
I believe in the governor's executive order 2020-36, it did provide recommendations for continuation of social distancing, physical distancing. If you're part of a vulnerable population, that those individuals continue to stay home and not go spend any long periods of time out in public or with with crowds. We're also, of course, still following those recommendations of making sure that you stay home if you're sick, and especially if you have any sort of symptoms. You can wear a cloth face mask or a cloth mask or a mask of any sort to try to create an extra level of protection, but that really is more for the people around you so that you don't share the virus, and doesn't really help on the other side of that. So we're going to continue taking those steps, and beyond that, I think the language that's in the executive order allows a lot of flexibility for businesses to make decisions.
Thank you, Madam Chair.
Okay. Any other questions? Thank you, Denise.
Thank you.
Okay, at this time, we'll go on to the next item on the agenda. This will be a discussion on possible action to approve and sign amendment number 3 to contract 18-P-05, unarmed security guard services to the
Mayor
U.S.
Schumacher,
Security
Mojave County
Association,
Public Health
has left the conference.
doing business as Advanced Security, Phoenix, Arizona, modifying the contract to add COVID-19. Additional site locations for county parks as a result of ongoing neighboring state restrictions causing a surge in Davis Camp Regional Park patron demand, and where additional security details will enhance customer service and support the general health, safety, and welfare of Davis Camp visitors, with all other contract terms and conditions remaining the same. Are there any questions, comments, or I'll entertain a motion? We have Michelle Fink in the audience if there's any questions.
I'll ask a quick question, just for clarity. Oh, no, it's more towards the parks. It's not about the contract. So has this been a big problem over the last month?
Madam Chair, Supervisor Angus, we've witnessed over the last 2 weekends historic numbers coming to Davis Camp. And out of the safety of our guests, after working with the Sheriff's Department and Risk Department, it is the recommendation that we need to bring additional security to the park. It is only going to be for Friday and Saturday and Sunday mornings. And we are also going to be implementing limitations. So we are actually going to start capping the total numbers that will be coming into the park. And we will be we do the wristbands on the holiday weekends, and we have decided to limit the number of wristbands so that we can start controlling the crowds a better, of which then the emergency traffic can have easier ingress, egress, and a little bit more control over the amount of the numbers. It's just the numbers that we're seeing are substantial.
Right.
Last week alone, we had over 7,000 people on Saturday.
So what's the number you're going to limit it to?
We are going to limit the numbers to 2,000 wristbands, but that's for adults, so you include families and children, as well as the guests that are already there. So I'd say probably it's going to be closer to 5.
5,000. Okay, and so what does this look like, though? I mean, what are they going to be tasked to do if people are gathering, many people gathering? Like, what are they going to do? Is it just for when there is some kind of altercation, or are they going to be proactive?
I've brought Todd here to assist as well, but mostly it's going to be proactive. It's also going to be for traffic control and ensuring that we don't have vehicles illegally parked and where they're not supposed to be parked, or double parking, and more or less just crowd control, overseeing it, and just making sure everybody's being safe.
Okay, and they're armed?
Yes.
Okay. And you can put out some kind of press release so everybody knows that this is going to be a new policy?
This is mostly for this coming weekend, but the way it's going in our summer, so possibly we're going to carry this on through the summer. We're looking at other avenues as we work closely with the Sheriff's Department as well, Supervisor Angus.
Okay, thank you.
Okay.
Okay, any other questions, discussion, or a motion?
Motion to approve.
Second.
Have a motion and a second. All those in favor say aye.
Aye.
Any opposed?
Aye.
Motion carries. This meeting's adjourned.
Ron Gould.